morning, everybody. Buenos días, buenas tardes, buenas noches para toda Latinoamérica. Gracias por acompañarnos. Thank you for joining us. And let's go. The idea of this space is just to facilitate interactions, conversations, sharing, knowledge sharing, and identify opportunities for, in a way, from the basic point of what are you doing, how are you doing, what did it take for you to get to where you are, which is something different than sharing your paper or your scientific paper. So here I am joining for what I thought was going to be Midday Australia, for this part of Australia, with various colleagues from Chile, Peru, India, and also from Australia. So off we go. The joint theme for today is mental health, and it's a joint celebration of World Health Day. Bienvenidos a todos. Hope you enjoy this session. So let's kick off. I suppose Soledad, would you go first? Remind me. Fantastic.
Soledad, you are mute.
Can you see my screen? Yes?
I can see your screen.
Okay. Hi, everyone. Thank you for this invitation. Thank you, Jaime, for this invitation. Thank everyone for being here. My name is Maria Soledad Burrone. With me is Dr. Maria Teresa Solisotto, friend and co-director of the project that we are going to share with you. We will present the result from a study we have done about the implementation process of a social innovation project for people with severe mental disorder and young adults with autism spectrum disorder in Chile. Can you see the PowerPoint? I'm so sorry, I'm confused. Can you see my screen with my PPT? Okay. Thank you. We will present this result and why did we develop this research and transfer project. 1 in 5 adults is disabled and 64% of these are women, more than have some kind of mental disorder. People with severe mental disorder are 6 to 7 times more likely to be unemployed. Studies show that there is a high degree of stigmatization and discrimination toward people with schizophrenia who want to work. 75% of employers report having difficulty hiring people with schizophrenia. The same situation happens to young adults with autism spectrum disorder. Stigma may contribute to low employment rates in adults with autism. This was one reason why we started this project, and the other 2 reasons were that the elderly suffer devaluation and loss of prominence and autonomy, low labor participation in women. Women suffer from inequity to be employed. According to the National Institute of Statistics in Chile, the employment rates are 21% lower among women versus men. They mostly have access to domestic work, services, commerce, and agriculture, with common characteristics of low salary, and this represents an extension of the work cultural assignment to women. Based on this, we create an initiative that will promote inclusion, generating competitive work opportunities for these people in the O'Higgins region of Chile. From a circular economy perspective, we articulate companies from the private sector, non-governmental organizations, the university, government agencies, and the community, of course. So as to promote work inclusion of people with severe mental disorder and people in the autism spectrum. There are important challenges for the effective inclusion in society of these people or this group. The Potenciate, this is the name of our intervention, support the creating of 3 work cooperatives for the social labor inclusion of people with severe mental disorder and young adults with autism spectrum disorder working together with women in vulnerable situations and older adults. As you see in this slide, we developed 3 cooperatives following a social inclusion perspective, community participation, recovery approach, and solidarity-based economy model. Each of the cooperatives includes 45 people, including 15 people with severe mental disorder or young adults with autism, 15 older adults, and 15 women with a vulnerable situation. Our hypothesis is that this cooperative will provide better support for people with severe mental disorder or young adults with autism and reduce stigma versus traditional social and health programs. This is what we expect to show after complete this project. How do we do it? First, socialize the project, identify a contract regional stakeholder, delimitate the territory, did a participatory diagnosis, identify potential participants, created network and cooperative, training the cooperative, and then provide technical assistance. These are some pictures of the cooperative. This is one cooperative of Rancagua. And this is another, this is a cooperative. And this is other. Along with intervention, we conducted quality and quantitative analysis, and Teresa will talk about that.
Thank you. We also have a research component in the project in order to assess the implementation process during different moments of the project using qualitative and quantitative approach, as Maria Soledad mentioned. In this last part of the presentation, we want to share with you some results of a qualitative analysis of the first phase of our project, from the beginning of the project to the definition of the work area of the cooperatives. We assessed 6 components. As you can see, we assessed the object and activities of the implementation, the perspective of some of the actors and users, but also the inner and outer context. In general, we found that the project was valued positively as a response to perceived needs, emphasizing a shared decision process and participatory approach. Users showed a high expectation related to the solidarity economic model, as well as physical and economic autonomy. All the activities were adapted to the participants' needs and especially to the context characteristics, especially considering the COVID-19 this year. Also, we found some barriers, especially related with cultural and auto stigma, and also some difficulties during the recruitment, especially in the pandemic. As conclusion, we can say that the project seems to be a good social and labor inclusion strategy that responds to the needs of the included groups. And you can see in the next slide, the next slide, please. Yeah, you can see some impression of the participants related to the inclusion, to some characteristic of the project related to the rescue of traditions, some comments about stigma, also some characteristics emphasizing the local relevance of the project, and especially giving value to the public funding of the project. The next slide, please. If you want to know more about our project, you can find it more information in the website. You can see the link. And also you can see some video in YouTube, and you can follow us in our social networks in Twitter, Facebook, Instagram, and LinkedIn. Thank you very much. And also in the chat, we are going to share a link of the video that summarizes in a really nice way and dynamic the project. So you can follow also this information.
Buenísimo.
Thank you.
Congratulations, Soledad. Congratulations, Teresa. Everybody's welcome to put some questions in the chat. So as we progress with the other presenters, you may have questions or specific details. I have just one question for Teresa or Soledad. How long did it take for this project to launch, for all the preparatory work? Because community engagement takes time.
Yeah, of course.
You can say that to the end. Go on, Teresa. Yeah.
Yeah, it has funding for 3 years, but also we have the institutional support of the university for 5 years more. And now we are in the 2nd year of the project. We are starting the 3rd year, and the participatory works with the community really took a long time.
Fantastic. And I suppose this is something that we can start seeing across the other presentations. Community engagement is important, it's essential, but nurturing it takes a lot of time. So we can learn from each other on that front. So let's progress to the others. I'm going to invite everybody to put questions. At the end, we'll have some time to get back. So Palab, 10 minutes for you. Let's move over all the way to India. Welcome, Palab.
Yeah. Is it visible? Is your screen visible?
I confirm. Yes. I can see it. Yes.
Yeah. Okay, great. Okay, so good morning, good evening, good afternoon, good night, whatever way we want to speak. I think we are spanning the globe here. And so what I'll be talking briefly is about a specific program called the Smart Mental Health Program, which I have been leading since 2014. And so it's almost 6-7 years now that we are doing this program in different avatars of it. And what I'll do is briefly give a background of why is mental health in such a situation that it is now. And if we look at some of the data that has been shown by Project Atlas from WHO, mental health law, which is I think an important component of any kind of program, is only available in only 63% of countries. So 1/3 of countries in the world do not have a mental health law. And only 2 out of only 40% of those which have a mental health law have actually revised it in the last 5 years. So it's safe to say that what they have is quite antiquated in many forms. Across the globe, and especially if you look at some of the specific WHO regions, the Africas, especially, and also the Southeast Asia region, we have very low number of countries which have actually any mental health law. When you combine that with the number of workforce that are there, yes, high income countries have almost 72 per 100,000 population mental health workforce, but low and lower middle income countries, some of the countries that are talking here, have very low numbers, 1.6 and 6.2, which is almost like 10 times less than that of a high income country. And then we understand what's the reason for that is the very, very abysmal amount of money that the government puts into mental health research or mental health programs for that matter, not mental health research. And the numbers here for low income countries is just about $0.02 US, which is just pitiable, given that if you look at the returns for investment for mental disorders. For every dollar spent, you get a return of investment of about $3 to $5. So it doesn't really make sense, and it's very difficult to understand why the government does not spend much more. Given all this background, if you look at India, a country of almost 1.4 billion people, we have almost 10% of our community which suffers from mental disorders in our National Mental Health Survey, which was done 3-4 years ago. And that amounts to about 150 million people, which is the population of UK and France put together. Self-harm is one of the leading causes of death in India, and there's a huge treatment gap that is almost 75 to 85 out of every 100 people in India or countries like India, low and middle income countries, do not receive any kind of mental health care for their illnesses. So seeing that, we thought of bridging the treatment gap using mobile-based technologies, because that actually makes sense because it helps to increase the reach of our program. And this was George Institute's flagship project. It actually started way back in 2008 as part of the Kannini Vascular Collaboration and started in Aboriginal communities in Australia, where smart technology was being used to increase cardiovascular care for cardiovascular diseases. And that platform was then taken to India, and the cardiovascular disease animals control trial was done between 2012 and 16. And the results of that have led to other projects, one of which is the mental health project. And this covers now a large number of population. We have also now taken this platform to other health conditions, whether it be mental health, diabetes, kidney disease, or high-risk pregnancy. So this is a typical area where we are working. It's a rural community in Andhra Pradesh, which is a South Indian state. It's a coastal district in South India. And the key strategies that we use are task shifting, using electronic decision support systems, incorporating those on a mobile platform, and then encapsulating the whole thing within an anti-stigma campaign. This is an area that we are in, sorry, the West Godavari district in Andhra Pradesh. And we had done this study in 42 villages and had covered almost 50,000 population. The main plan was it starts off with a household screening, following which the non-physician health workers, they identify people who are at risk of common mental disorders. Here we are talking of depression, anxiety, and increased suicide risk. They refer them to the primary healthcare center, where the doctors are able to look at their symptom profile and to treat the patients using WHO's MHCAP tool. And then that information is shared with the non-physician health workers, who are called ASHAs in India, and they are able to manage treatment adherence. And then we as researchers do assess the whole fidelity of the program. We monitor the program and also do evaluation of the program. So overall, over the 1 year period that the intervention actually was operational, we found that mental health services use increased from a baseline of only 3%. Only 3 out of every 100 people with any mental illnesses were seeking care before we went in. Over the 1 year period, that went up to 81%, which was a huge, huge increase. Depression and anxiety scores also reduced significantly over that same period. And this also helped us to roll out a large anti-stigma program, which in fact is the largest evaluated anti-stigma program in an LMIC, and is one of the only studies which has a longitudinal data. Feasibility of providing mental health services using technology was also established as part of the program. So this then led us to a new project, which was a cluster randomized controlled trial, which was funded out of the GACG program and through NHMRC. This is now being scaled up to 2 states, Andhra Pradesh and Haryana. We are going to a population of 165,000 across 44 primary healthcare centers. It is a cluster randomized controlled trial. And this trial is underway now, and the intervention phase is ongoing as I speak now. It also led to another project. This was funded by MRC UK And just also was taking the same principles, but putting it into adolescents in urban slum communities. And here we were looking at, again, scaling it up into 2 states, Andhra Pradesh and Delhi. We will be going to 70,000 adolescents. And that study just commenced late last year, will be running for 3 years. And again, it's a cluster randomized controlled trial. I would like to acknowledge my funders who are listed here. And if there are any questions, please call me or link me through this email, and I'll be happy to respond to them. Thank you so much.
Olaf, thank you very, very much. And was Pancho from Peru PPS. Another reminder for all the participants to place their questions on the Q&A section. And congratulations. I suppose I will have time to discuss soon about the COVID implications of deploying such large operations and fieldwork, which I suppose will be common across projects. Let's try to catch up with time. So let's progress to Pancho, please, and then we'll answer questions later. Over to you, Pancho. Let's travel all the way back again.
Thank you, Jaime. Can you hear me well?
I can, yes.
Yeah, I will share my screen. Can you see it?
Yes.
Okay, thank you. Thank you, Jaime. Thank you to all of you. Good evening to all from Peru. Buenas noches, America Latina. Thank you for the opportunity to share some of the experiences of our work here in Peru. So we are going to describe small bites or sips of our experience here in Crónicas, where I work in the next 10 minutes. My name is Francisco Diez-Canseco, and I'm a researcher at Crónicas Center of Excellence in Chronic Diseases. Crónicas is a center that was funded almost 12 years ago, and is based in a Peruvian university in Lima, the capital. The focus of our research is NCDs and mental health, basically. And one of the aims that we define of the center was to improve the health of the community doing high quality research. That means that we usually try to, not always successfully, but we try to work with and within the health system in Peru. And when we do mental health research also, no? So how is doing mental health research here in Peru? That is what I want to share with you. It means on one side that we need to cover all the cost of the center. We are only funded by grants, which means that we need to produce a lot of proposals every year to compete, but with the extra challenge that there are almost no local funds for mental health research in Peru. So all the projects that I have here in mental health are funded by foreign institutions, UK mainly, but also US and Canada. So I think that opens a question of who defines the research agenda in Peru and in the LMICs if we don't have funds to invest in our own research, no? Who define the relevant and the right topics, the questions, the designs, and we finally implement in our countries, no? However, even when we know that this is a relevant question, here we locally try to define our own agenda in some ways, no? On one side, we try to let some of the collaborations that we do with UK, US, and the European Union. We usually, not usually, but sometimes are the lead institutions. But we also invest in a relationship with the local policymakers in Peru, so they also can help us to define the content, the aim of the proposals that we do locally. No? For example, with the policymakers in Peru, and I know that there are some in this webinar, we have 2 collaborative studies, and we have produced together with them three common papers where they are also co-authors. No? So what is the setting in which we are working? No? Peru, as many other LMICs, has a high prevalence of mental health disorders, a high burden of disease related to these disorders, and a high treatment gap for mental health disorders. What is singular in Peru is that we have a mental health reform that started almost 9 years ago, that was expressed in political commitment. So we have a mental health law, a mental health regulations, and a strong policy in terms of human rights of the patients. And there is also an important financial support. And the idea is to introduce a community mental health model in the country. So less psychiatric hospitals, strengthening primary health care, and creating community mental health centers in the country. We currently have 200 community mental health centers in less than 5 or 6 years. And the plan is to have 300 in the next couple of years. And an information that I think is relevant and really unusual is that the policymakers that are leading this reform has been leading the mental health directorate during the last 7 years. In the same period of time, we have had 12 ministers of health in Peru. No? So it's really key that we have the same people leading the process locally. So the reform is also an opportunity to do research in Peru, because the system is looking for options to improve and implement innovative interventions in the system. So I'm going to share 2 slides of each of the next projects. No, they are not huge projects. Palab has presented some samples that scare me in terms of the amount of people. These are quite small projects. The Ayanchu project that was a pilot of a mobile health strategy to promote the detection, referral, and access to treatment of people with common mental disorders. Then a project that we did together with the Ministry of Health to strengthening the continuity of care program. So we assessed the implementation of the program, and then we co-developed a monitoring system with the Ministry of Health. And the last one is a project we are just starting that has been named Heartbeat Creating Recovery. And we are going to do an assessment of the transfer of some virtual theater-based methodologies to work with people with autism from UK to Peru in the context of the COVID pandemic. So let's start with the first one. The Ayanchu project that was funded by Grand Challenges Canada. Ayanchu is a greeting term in indigenous language here in Peru that means how are you feeling? So it's more than just hello, no? And the intention was to invite the primary healthcare providers to start assessing the mental health of the patients in the regular consultation. So we wanted to promote early detection, opportune referral, and access to treatment of people suffering from common mental disorders. What were the strategies that we used? 3 strategies. We train people in the primary healthcare system. We develop an app for screening common mental disorders within the regular consultations. And we developed a system of SMS to remind the people who was detected of a case and motivate them to look for help within the health system. So what we have were a group of patients going to regular consultations, people with tuberculosis, HIV, diabetes. They were screened by nurses and midwives using a tablet in the regular consultation. Those who were positive were referred, and we additionally sent some SMS to those who were referred, so invite them to look for mental health care and access the system finally. What did we find at the end of this pilot study? During the 9 weeks of the pilot, around 700 patients were screened during regular consultations, so by the own motivation of the providers. 1 in every people that was screened had a symptom of a clinical depression or anxiety syndrome. And interestingly, 7 of each 10 of those positive cases, with invitation of the provider, finally sought for specialized care in the system. And 5 of every 10 of those positive patients receive specialized care after the suggestion of the person who is screened these people within the regular consultation. Then we interview the providers and the patients. The patients value the screening as positive, and the providers found the use of the app as something easy to use, but challenging with the small time they had within the regular consultation. So there was a challenge we still need to address. The second project is the project to strengthening the continuity of care program for people with severe mental disorders in Peru that was funded by the Pan American Health Organization. I have 2 slides of this small study. So the continuity of care program is a key program in Peru in the part of our mental health reform, and the aim is to improve the quality of life of the people living with severe mental disorders, linking them to their communities. And that means giving them a closer and more intense support during the treatment. So the problem or the challenge is that this program is going to be implemented in almost 300 community mental health centers, but it doesn't have a monitoring system. So we defined together with the Ministry of Health, and I think that is the relevant part of this proposal, we defined to assess on one side the implementation of the program, and on the other side to try to develop a pertinent and a simple set of indicators and procedures to monitor the program in the next years. So we did a one-year study when we reviewed some documents with indicators in other programs in the world. We performed a qualitative study, and we did a validation process of the monitoring indicators and procedures with workshops with health professionals and policymakers in Peru. The outputs of this study is that we have a common paper with the people from the policymakers from the Ministry of Health, and we have a set of 24 basic and easy to measure, easy to use indicators that are aimed to measure the process, the results, and the satisfaction of the patients of this program in the next year. So the next step after the COVID, if that is going to happen soon, is to piloting this within the health system and with support of the health providers. And finally, just a couple of slides of this project that we are starting, and I'm just sharing this because to show the diversity of projects we are trying to do here locally. Is a project that we call Heartbeat Creating Recovery that we are doing with Queen Mary University in London, and also with Flute Theatre, that is a company in the UK. And it's a case study to see how we can build inclusive learning through the use of theater in the context of the COVID pandemic. So this is my only slide of this project. Flute Theatre is a company in UK that during the last 20 years has developed a method that is called the Heartbeat method. That there is a definition there that I'm going to read. That is, there is a set of games that are inspired on some plays and characters of Shakespeare. And the idea is that these games offer people with autism the opportunity to express themselves, to explore eye contact, language skills, spatial awareness, facial expressions, and imaginative play. They have done this during 20 years in person, and during the COVID pandemic, they moved all the method to the Zoom. So that means that you don't need to be in London to receive this interesting work, and they can share this with the world. So we get funded to a project where Flute is going to share this with a Peruvian company of theater that is called La Plaza, and we are going to be the research arm of that project to register the experience of moving this experience from UK to Peru, and then possibly from a theater company to government, civil society, and community institutions in Peru. If you have time and you're interested, please look to the website of Flute Theatre. They are doing an amazing job, and they are open to share this with the rest of the world. So I think that's all. Feel free to send me an email if you have questions or suggestions regarding our work. Thank you.
Oh my God, I'm salivating given the breadth and the range of activities where mental health can be served, can be progress can be made in the field of mental health. So let's continue with the questions on the Q&A section and the Zoom, and let's move quickly to Simon so that we can have a joint conversation afterwards. So Simon, over to you.
Thank you very much, and thank you for giving me the opportunity to talk today. I'll be talking about a randomized controlled trial we did looking at volunteering as a healthy aging intervention with a strong mental health focus. And an important point is that this is about prevention, whereas I think most of the other presentations today have been focusing on treatment. Our aim is to work with people, community, older people. They're not institutionalized, they haven't been diagnosed with any kind of condition yet, but can we use volunteering as a way to keep them happy and healthy for as long as possible in their homes? Next slide, please. So the definition of successful aging comprises the three elements that you can see there: disease and disability avoidance, engaging with life, and high cognitive and physical function. And obviously there are mental health and psychological health components relevant to all three of those. Next slide, please. Now, when we pitched our grant to the Australian Research Council, we were very interested in mental health implications, but we pitched it all around economic implications. So we were able to say to them, look, when people get to about 60, we have that really large trajectory upwards in terms of per capita health costs. So what we need to do is move this graph sideways to the right so that that kick up happens much later in life. And we pitched it around the fact that this will save the economy a lot of money, but obviously this is also going to make a lot of people healthier and happier. Next slide, please. And if we think about, and apologies, this is a very Australian context, but these are our demographic pyramids from say about 2013 through to about 2050. And you can see the population is growing, so it's going outwards, but it's also going upwards. So we're getting definitely older as a population. In the left-hand figure, that little kick out at about the age of 67, that coincides with retirement age. And then you get that strong trajectory where we reduce in numbers from then on. As we head towards the middle of the century, that little tick area is up around the age of 80. So we're going to have people for many years in retirement without necessarily the purpose in life that they would have had through employment or through having close families. So what are we going to do with all of those people for those years to keep them as good a shape as possible? Next slide, please. So what we really need is something that constitutes what we would call a silver bullet. Something, because we're in such a constrained preventive health environment in terms of resources, what could we allocate funding to that would help tick off all three of those different areas of successful aging? Next slide, please. So there's been quite a lot of anecdotal, mainly cross-sectional research that indicates that volunteering is good for all of these different outcomes. They're physical and they're psychological and they're social. But we don't really have anything definitive to prove that's the case. There's only been 2 or 3 longitudinal studies, and they have all been based around childcare. So waitlisting people or allocating them to childcare volunteering and seeing what that does longer term for their physical and their mental health. But these people had already self-selected as wanting to volunteer and wanting to work in childcare. So it's not really representative of the general population. Next slide, please. So our randomized controlled trial was quite modest in size. We only had 400 people, 200 were in a controlled condition and 200 were in a volunteering condition. And this was the fun part, because we recruited older people to come into a healthy aging study. And once they'd signed up, they then either got allocated to the control condition, or we had to try and talk them into going out and getting volunteering work. And we managed that with virtually all of them. The attrition was very low, fortunately. So they only had to do a minimum of 1 hour a week. Some did lots more, but some stuck to their 1 hour a week, and they could do it in anything that they chose. So some went out and collected rubbish from the verge. Some did childcare or elder care kind of responsibilities. Some went out and planted trees for environmentally friendly organizations. There was a huge range there. Next slide, please. The inclusion and exclusion criteria were quite specific to make sure that everybody involved in the study was retired, so that we didn't have employment effects contaminating anything. They had to be age 60 or older. And one of the limitations of the study was that they had to be fit and well enough to be able to come on campus for a whole range of psych and physical tests. So it did kind of limit the range of people who could participate in the study. Next slide, please. We had a whole range of pre-post measures at time 1 and then at time 2, which was 6 months later. And I'll talk you through each of those. They had to come on campus twice, 1 at each time point. They had to maintain an activity diary for us every single day for 6 months. They wore an actigraph for the first week of the study and the last week of the study, and they had to wear a pedometer for the 6 months in between, and they had to diarise their step count every single day. Next slide, please. So it was quite an onerous study for participation. They're the psychosocial measures, 8 different variables that were assessed for mental health. So psychological well-being, depression, self-esteem, quality of life, personal growth, purpose in life, social support, and self-efficacy. Next slide, please. And we also put them through the grill in terms of a whole range of physical tests. We took their BMI and girth measures, blood pressure, heart rate, etc. But then we made them do a whole series of upper and lower body strength tests. and gait tests as well, forward and backwards walking, fast pace, normal pace walking, and what's called a sit to stand test, which means you have to sit up and sit down and sit up rapidly 5 times in a row. Next slide, please. For doing all of this for us for 6 whole months, they got $200 each, and that had to cover their transport and parking costs, as well as reimbursing them for some of their time. And in terms of converting that into a different metric, that equates to around 40 cups of coffee. Next slide, please. Now, after the 6-month point, and everyone had been told when they were recruited that they would be in this study for 6 months, relative to control, people in this volunteering condition had improved on sit to stand and 6-meter fast-paced walk scores. And this is really good because those 2 measures are indicative in a whole range of studies of improved mental and physical health. Next slide, please. But interesting, of course, was that our control wasn't a real control. They were part of a study, so they were kind of volunteering with something already. Plus, we were sensitizing them to their activity. They had to fill in those activity diaries. They had to get their step count written down every day. So that kind of really got those people improving as well. So across both the control and intervention conditions, we saw improvements in those variables listed there: the backwards walk, leg extension, seated row, purpose in life, self-esteem, and social provisions. So this made us curious because it was only the physical measures that improved over the 6 months and none of the psych measures did, but they were trending in the right direction, and we had seen some improvements across both groups in the psych measures. So our lovely seniors, we went out to them and said, we've got no more money, we can't give you anything else, but would you mind still answering our surveys for the next 6 months? So we didn't take any more physical measures, but we kept on going with the psych measures. Next slide, please. And we found out that 6 months later, we've now had significant improvements relative to control in people who volunteered in life satisfaction, purpose in life, and personal growth, which was as hypothesized and a good outcome. Next slide, please. So it looks like volunteering actually is a kind of silver bullet. So not only will it really help our economy when we can have people actively out there still being engaged, still being productive, but it can help across a whole range of psychological and physical measures as well, which will make our population healthier for longer. Next slide, please. And just a little note on working with older people, I strongly recommend it. They always turn up. I think we only had 1 or 2 no-shows across the 800 visits that they had to come to, and that was because those people were really ill. They usually come early. We learned very early on that you have to turn up half an hour before you ask them to come because they'll be there and they'll be waiting. Very high compliance with quite an onerous study. They really like a chat. They were just gorgeous to work with, and they really want to hear about the results. So we keep sending them out papers and they keep replying, telling us they've read them and finding it all very interesting. Next slide, please. And a shout out to the team who helped with that project over the last couple of years. Thank you very much.
Thank you, Simone. Thank you, Simone. That's, I'm so pleased and excited to see that given the theme of today of World Health Day, the number of studies that have been shown and shared have spanned across all the life course, from adolescence and infancy and theater and all the way to senior population. Different themes. I really much value how you have articulated this in terms of societal and economic terms, and some others have articulated within community, some others within health systems and so on. And importantly, the diversity of conditions as well that are being tested. So this is for us to say that, yeah, there's no health without mental health. So congratulations to all of you. Congratulations for leading all this exciting work. And sorry, my signal is not that bad, but there was a car park in the front room. I decided to switch rooms. So I'll pass on to the questions. There are some questions there, people who may want to reflect, or I'm happy to start with all of you. If you want, for each of the speakers, if you want to share your main challenge today, communicate with the audience, what would that be? So let's start with the same order. Soledad, Olaf, Soledad and Teresa, Olaf, Pancho, and Simone. Main challenge of working with us. One short sentence. Well, let's wait until they're ready. So, Olaf, are you willing to go first?
Sorry, I couldn't hear you properly. Can you just repeat yourself?
I was asking to all of the speakers, if you were to reflect backwards and share with us one of your main challenges working on mental health.
During the COVID times?
It can be, yeah.
Yeah. Yeah, I think COVID was a major challenge, especially for a community-based study of the magnitude that we were doing. And for a whole period of the lockdown, the study had to be stopped. We also had to go back to ethics committee because of the delay that happened. We had to refine the outcomes, because one of our outcomes was the proportion of people who would go into remission. That was a primary outcome when we had started the study. But in psychiatry, people who are group who are here and people who are aware, there is something called natural remission. So if we wait for 6 months, there would be natural remission that would happen anyway. So we actually had to go back to ethics committee to revise those primary outcomes and make it more continuous based on changes on scores of PHQ-9. So that was one. But then there was the whole challenge of engaging with our non-physician health workers. We had to stop at many times because of the restrictions that were there. And but we used the time in between to actually talk about COVID and to share information about COVID, both with the government as well as our non-physician health workers, to train them about COVID appropriate behavior, about sanitization, about physical distancing, about all of those. So it was a good learning experience. And the final piece was obviously some of this work had to be moved from face-to-face to online modes. So we had to, again, rethink the whole process.
Thank you, Pilar. Thank you. So, Pancho?
Yeah, I think if I need to choose one challenge is the commitment of the system when we propose interventions. And I'm not talking about the heads of the system. They are always open and we have a good relationship there. But I think that in Peru, the system is not a whole piece. And if you talk in the top, the things are going to happen in the bottom. So I think we usually need to negotiate at different layers and sometimes almost with every person within a health center. Not every person has their own opinion, so they can say yes or no by themselves, you know. So I found difficult sometimes to do big studies when I see the numbers of PALAP, no, with 70,000 adolescents, no. That sounds like a huge work. So I think that is the main challenge, to really convince the people that works in the system that being part of a research is a good idea, and really understand what are the motivations to be involved in this type of processes. I think that is the main challenge.
Thank you, Pancho. Thank you for sharing that. And Simon, because I suppose each of these challenges can be a whole set of conversations. I don't know if we can continue if we have time. But Simon, your reactions.
Yeah, I think the challenge when you're looking in prevention is even a little bit more difficult, because the focus is very much on how do we deal with the cases that we have in front of us. So we're trying to get people to say, let's prevent tomorrow's mental health problems rather than addressing today's with some of that funding, and that's difficult. And you layer on top of that the fact that we prioritize older people, and that's also not a priority for many governments. So it's always around reframing the issue in language and in challenges that the government and the funding bodies are concerned about that may or may not be your primary focus, but you can pitch it in a way that they can relate to and can see some value. Shouldn't have to be like that, but it is.
Yeah. Isn't it that working on prevention is always harder across fields? So yeah, another challenge that relates to other fields. So let's try to get back. Soledad and Teresa, okay. Did you hear the question?
Yes, and we think that the one challenges of our project was the recruitment. we have two very heavy moments. Of course, the COVID pandemic and conflict social in Chile. Both was difficult for our project.
Yeah, and also we have to move all the community participation to Zoom, to digital format. So also it was a big challenge because we also are working with the older people. So it was a main challenge to try to familiarize with the Zoom or digital platform. I think it was a challenge, but we did.
Hold on. Because that's a challenge for everybody having to transition. But that transition to Zoom, Pancho has given us an example of Zoom theater. Pancho, what was the reception? Were people engaged? Were your target audience engaged? A little bit of that initiative to share with us, please.
Yeah, you need to see the flute work. It's amazing how the people with autism is enjoying the 1 hour. It's 1 hour of a representation where they are part of the group of actors. So it's 6 actors and actresses and 1 person with autism. So all the play is around this person, and the level of engagement is incredible. You need to see it. And then when you hear the families talking about the experience and how you put in the center a person that is usually invisible for our society, at least, that is an amazing experience. No, the idea that you provide an opportunity, no, to be the center of something. No?
It's one patient center.
Yeah, it's 1 person. Yeah. So you have actors, and then you have a Shakespeare play with games, and everything goes around this person. And it depends. There are some person that can do more games and others that just do 1 game, that is say hello many times. No, it's just, and they really connect with the actors. It's
language,
really
Pancho? Is it run in English?
I mean, for this project in Peru, it's incredible, but the UK actors has learned some Spanish words. You don't need to use a lot of language, of words, but they have learned some words. And yeah, and it goes really well. You don't need a lot of English or Spanish or whatever, and they are doing this now in other countries. No? So
fantastic.
Yeah. And the idea is to create a local set of actors in Peru that can continue this work, and this can probably happen in other countries also. No?
Or thinking now we can get some of Simon's volunteers, elderly volunteers, to be actors for these youngers.
Could be.
I mean, you can train both. You can reach out into more people within it, but also you can expand your workforce. It's a set of actors for one patient will be a limitation.
Yeah, that is part of the discussion of the project, you know, to assess the feasibility of doing this and how to replicate this in the local communities. You know? But you always have a local theater group in the communities also, no? So you can link that to the schools or the centers or the health centers.
Okay, I'm gonna invite those who are writing on the chat, because I as you can see, I'm with my cell phone. If I put my finger there, then I start to read. Any of those of you who have written questions on the chat, would you like to come out and ask them directly to one of the speakers? Now that I'm putting you on the spot, if not, let me try and pick up one. Theater. So Catalina, do you feel that satisfied with the answers? So there is about the theater, and Christian. And I think I saw somebody else asking about the referral. I suppose it's a Pancho by your example of Ayiyancho. So can you clarify when people got referred and they got seen, was that part of the project activities? Did you hire people? How was the referral?
No, if you receive attention was within the system with the resources of the system. But what we found is that the primary care providers that were doing the screening, since they have a huge level of commitment, they usually help the patient to go from a positive screening to the specialized care, no? So they help to navigate the system, and knock the door of the psychologist to see if you can see my patient that I have found that is depressed or anxious or something like that. So that was something that really helped in the project, but we didn't pay anybody to provide care in the system.
So it was a true example of working with of the existing resources of the system.
Yeah.
Thank you for that clarification. I'm gonna ask, as we're reaching time, I'm gonna ask in the opposite sequence, I'm gonna ask first Simon, Pancho, then Palab, and then Soledad. If you were to think after this conversation, if you were to think about your research, what ideas are you cooking right now? So what has caught your attention, and how can you link some of the experiences that you've heard today with some of your other ongoing work, which I suppose is tremendous and difficult to summarize in 8 minutes. So Simon, Pancho, Palab, and then Soledad.
Well, Palab just emailed me and said, wow, we could look at doing a similar kind of study in India. So I think the cross-fertilization, the kinds of studies that we're each looking at doing here, the ability to be able to translate that to some of the other national contexts would be great.
Fantastic. Thank you, Palab. You're on mute, I think. Palab, you're on mute.
Sorry. so I think, yeah, Simon's work would definitely be something of interest for me. And so I'll be looking into that further. But also I was quite intrigued with flute theater concept that Pancho was talking about. And I think I and he should be having a discussion about it. We also are using theater as part of our anti-stigma campaign. And but that is more a community-based theater groups who talk about mental health and issues around that. But what he is talking about seems also interesting, especially from an autism spectrum disorder perspective. So I need to learn a little bit more about that.
Thank you, Palab. So we're wrapping up. Marinka is gonna help me on time. So Pancho.
No, I think the same. I think I can find something in each of the presentations, and yeah, and I think it's good to have this space to share. No, I was thinking in what Maria Soledad was presenting, for example, and how this can be linked to the continuity of care program in Peru that works with people with severe mental disorders, for example. No? So, and I know that there's people from the Ministry of Health here now listening this conversation. No? So I think it's a nice space to do links, and there's other people now asking in the chat. So great to have this opportunity.
Soledad, Teresa?
The same of the rest of colleagues. I think it's very good opportunity to share this proposal, and that said, Pancho, I think it's very interesting to see the different movements of the people and maybe complete the continuity of care. I think it's a very good opportunity, and thanks for.
Thank you. Let's see, was that Sole or Teresa? So let's see. So, I suppose the spirit of, the purpose of this session is, back in the days, we will all travel to scientific conferences and we'll have this very rigid space where you have your methods, your results, and you try to compete for attention. This my result is more interesting than yours. And but now we are in the new era, post-COVID, and we still need to facilitate and to enhance our collaborations. And I suppose this format of having very short presentations and providing a sample of where your interests lie, have you done certain studies, how to hear from each other, will facilitate new opportunities to collaborate and to build together a better and a fairer world. That's the label of today's conversation. So I want to thank all the speakers. I suppose we could continue for another hour talking, but let's keep it simple this time. The channel has been opened, the door has been opened. People are very willing to share, and all the participants as well, feel free to reach out, to write, to ask. That's the intention of shared knowledge and progress and advance the agenda of mental health. So I'm going to stop here. I want to say thank you for also the organizer and all the help and in putting this together, all the comms team behind us that you see some names there helping us. And thank you for all the speakers and to all of your teams as well, working with you, producing this important research. And we shall be seeing each other with another topic in a month's time. So stay tuned. Bye for now. Adios.
Thank you.
Gracias. Ciao,
Bye.
bye-bye.
For the invitation. Bye-bye.
Gracias a todos.